very close attention to the concentration. Okay, you have the name, you have the concentration. You'll have Omnipaque 180, you'll have Omnipaque 240, 300. So the higher the number, the more iodine that it contains. Omnipaque is non-ionic. IsoView is ionic. You don't have to write that down. So the Lowell osmolality, okay, that would be your non-ionic. They're more expensive, anywhere between 6 times more than the ionic version. However, you have the less chance of a reaction. It's less lethal. And I mean, if I were the manager of the department, I would go ahead and spend extra money on this, because if someone had an allergic reaction, that costs more. You understand what I'm saying? When you talk down to economics, if someone has an allergic reaction and then they code, that's more expensive. And not only that, but you may have lost a life. So that you can't put a price on. All right, so side effects. A side effect is an expected outcome to injected contrast media. Common side effects is temporary hot flush, metallic taste in the mouth, some warm feeling throughout the body, maybe some stinging at the site of injection. That's temporary, right? What's another name for that? Transient. Transient. Okay, you guys remember that? This is transient. It comes, it goes. Whereas a reaction is an unexpected outcome of the injected contrast media. You have minor reaction, intermediate, and then worst case scenario, you have your severe reaction, which may lead to shock. A vasomotor effect is a non-allergic reaction based on fear or anxiety, usually non-threatening. Okay, non-allergic reaction, this is just anxiety. Okay, about the tests, about the results, about what's going to happen. Okay, all those cause a vasomotor effect, which causes lightheadedness, nausea, feeling faint, and also possible mild urticaria. And what's urticaria again? Okay, mild hives. Okay, hives. Okay. Okay, so that's non-threatening. Okay, an anaphylactic reaction is a true allergic reaction that may lead to life-threatening condition. Now again, this is where I contest what's in the book, because it's not a true allergic reaction. It's anaphylactoid. You guys got tested on that, right? It's anaphylactoid. Because it's not the person, they're not allergic to the contrast, they're allergic, it's a response to the contrast and the release of those histamines and complements and things of that nature. But it's not a response to an antigen, per se. The symptoms includes moderate to severe urticaria, laryngospasm, bronchospasm. Remember those complements in those histamines, that's what causes the smooth muscles to contract, making it difficult to breathe, giving you those stomach cramps that affects your GI system. It's also going to cause low blood pressure and also increase your heart rate. Now, this is what's called vasovagal reaction. Don't get that confused with vasomotor effect, okay? They sound very, very similar. So a vasomotor effect has to do with anxiety, excitement, stress. Vasovagal is where the contrast agent stimulates the vagus nerve, causing a drop in blood pressure, heart rate, and then it becomes a medical emergency. Remember what we said, normally what your body does is that it compensates for changes in your blood pressure and also your heart rate. They should compensate. If one goes up, the other one goes down. Now, if both of them are going down, now you're in big trouble, because low blood pressure, low heart rate, there is no blood circulating, and you're in big trouble. Okay, contrast, okay, acute renal failure, kidney shutdown. Symptoms includes diminished urine output and also anuria. So that is diminished or infrequent. That would be oliguria. Anuria just means no urine at all. You guys remember oliguria? Mm-hmm. Okay, infrequent or diminished. Mild reactions includes nausea and vomiting, hives, itching, sneezing, extravasation, also a vasomotor response. And then we talked about extravasation versus infiltration. So part of the things that you're going to have ready in your room is you should have some towels ready, just in case you do have some issues with extravasation or infiltration. You should have towels ready in case the patient feels nauseous and they want to throw up. So you have those available. So that's part of the equipment and things that you need to gather for the procedure. Moderate includes excessive urticaria, increased heart rate. So again, as it gets worse, your heart rate's going to go up. If heart rate goes up, your blood pressure may drop. And then you have your giant hives and excessive vomiting. Technologist responsibility during moderate reactions, you're going to call for medical assistance. Monitor and comfort the patient and document patient reaction. So you shouldn't be leaving your patient at all who's received any type of contrast agent. I'm talking about the IV contrast. They should not be left alone because there may be a latent effect. You might not see an immediate effect, but there may be a latent effect. And so if they do, and you're not in the room, now what? You're not there to tend to that patient, and now you literally can have a medical emergency. That started off as just something being minor. Severe reactions, very low blood pressure. Then you have difficulty breathing, and your heart rate is all over the place. Patient can lose some consciousness, go into convulsions, and you have laryngeal edema. You start to get swollen, and then your respiratory tract starts to contract. Cyanosis is an indication that your body isn't receiving adequate amounts of blood. Okay, and then eventually it leads to shock. Now, where do we perform iodinated contrast procedures? IV contrast procedures.
CT.
Okay, in radiology, what should you, okay, let me rephrase this, that was kind of vague. What should you have in your room if you're performing these procedures?
Crash cart.
A crash cart, okay. It should be easily accessible, easily. Okay, radiographic urinary procedures, and again, the key here is that the routines may vary depending on department protocol. So what we're going to cover is just the basics. Again, they can vary. So the first one here is an excretory IVU. Okay. Again, it's the correct term versus IVP. So IVU is more common, and it's a radiographic examination of the urinary system. The purpose of it is to visualize the collecting portion of the urinary system and assesses the functional ability of the kidneys. Just like the small bowel, you guys remember the small bowel? We take pictures in increments, time frames, intervals. We also do that with the IVU or the IVP. It also is time because it's a functional study. Contraindications for use of iodinated contrast includes hypersensitivity to it. Now, if you recall, just because you don't have any allergies or history of allergies, can you still have an allergic reaction? Sure. Yes. And if you had an allergic reaction to the contrast one time, is it possible that you may have it the next time? Yes. Yes and no. Yeah.
Oh, it's possible.
Yeah, it's both. Just because you had an allergic reaction before doesn't mean you're going to have it the next time. It's idiosyncratic, it's anaphylactoid, it's unpredictable. So if you have diabetes, that might be a contraindication, because diabetes may indicate renal dysfunction, meaning that if you have diabetes, your vessels are very small, which also means your arteries to the kidneys, the veins coming from the kidneys can also be very, very tiny, meaning that your kidneys aren't receiving adequate amounts of oxygen and nutrients to keep it healthy. Okay? Remember, with contrast, it makes your kidneys work harder than it's supposed to eliminate. Asthma or other respiratory conditions, it may induce exacerbated bronchospasm. Multiple myeloma. Okay, multiple myeloma, that refers to disease of the blood cells. The blood cells produced in your bone marrow, so this may also indicate renal dysfunction. Severe dehydration may cause osmotic shifts and impaired blood flow. Remember, contrast is going to steal fluids from its surrounding tissue to equilibrate, okay, to dilute it, and so now stealing fluids from its surrounding spaces. So if you're dehydrated, you should not be doing this. And then if you have chronic kidney or hepatic disease, you don't want to mess with that. So down here, individuals with very poor cardiac function or hepatic compromise have increased lactate production or impaired lactate breakdown, and also are at a risk of developing lactic acidosis. When you have lactic acidosis, your circulating blood has an inability to hold on to oxygen. Okay? It has an inability to hold on to oxygen. So cells do not receive adequate oxygen and may be fatal. Okay. Contraindications continued. Anuria. Well, if you're not producing urine, what produces urine? Kidneys. So if your kidney's not producing urine, that's a good sign there's something wrong with your kidneys, right? Severe hepatic and renal disease, we talked about that in the previous slide. If you have a heart condition, we mentioned that on the previous slide. Pheochromocytoma is a rare tumor. Anything that has to do with the kidneys, okay, it's a contraindication. If it has to do with blood, it's a contraindication. Okay? Sickle cell anemia can compromise function of kidneys, may cause red blood atrophy and increase risk of sickle cell crisis or reduced blood flow. Glucophage. One of the questions you're going to ask them during your clinical history is, are you taking glucophage or are you on metformin? Those are the two common names for this medication used for what population? Diabetics. Okay? So if you ask them if they're diabetic and they say yes, your next question will be, are you taking glucophage or are you on metformin? So if they are, you need to ask them if they've withheld their glucophage or metformin for at least 48 hours. Because if it's still circulating in your system, contrast can slow the elimination of metformin, and can be toxic, causing lactic acidosis. Remember, again, if you're any type of metabolic acidosis, your cells is compromised in holding on to oxygen. You get very compromised. And so if you're not circulating oxygen systemically, your body can go into shock. Okay? So again, are you diabetic? Are you on glucophage or metformin? And did you withhold it for at least 48 hours? And that's going to be part of your dialogue. Okay? This is kind of, I don't know why this is really up here because it's not necessary. What is good to ask is that usually patients who have a procedure like this, the pre-medication that we ask them about is if they had any type of Benadryl or steroids prior to having them come to the department. You guys remember what Benadryl is? Mm-hmm. It's what?
Antihistamine.
Antihistamine. And what is steroids? What do they do? muscle relaxer to counteract any type of muscle contraction as a response to the contrast. So those are the things that we need to ask them. Did you take your Benadryl? Okay. This just refers to, you know, if you're dehydrated, they just want to make sure that you are hydrated. That's all. Lasix is a very common type of diuretic that, that keeps the patient very, very wet, so to speak, hydrated. All right, let's go on to pathologic indications of radiographic urinary procedures. Clinical indications. First one here is an abdominal or pelvic mass. Second one here is renal or urethral stones, kidney trauma, flank pain. You didn't pull back muscle. Okay, you know you didn't injure your back. Most likely it might be kidney problems, stones. Hematuria, what's that? Blood in your urine, hypertension, renal failure, urinary tract infection. All these are indications for an IVU. Now, if you look over here, it says unusually large calculus in the right ureter.
What?
Wow, that's a stone. That's huge, right? And not only that, but the urine has nowhere to go, so it backs it up, and now you have distension of the collecting system and the renal pelvis. This is actually called hydronephrosis. Hydronephrosis. It's an enlargement of the collecting system due to maybe a stenosis or a blockage of some sort. Because here is what it's not supposed to look like, and this is what it's supposed to look like. This is normal. Okay, we're also going to do it for enlargement of the prostate, congenital anomalies to analyze different types of anomalies, including duplication of ureter or renal pelvis. So you can have duplicating systems. There are patients who have 3 kidneys, 4 kidneys. Horseshoe-shaped kidneys. It's just an abnormality. It's just an anomaly. Doesn't mean they are still 100% functional. Malrotation, on the other hand, if it's rotated, that might also mean that the ureter might be twisted. Cystitis, more common in women because of their short urethra. I think that is a test question. Cystitis more common in women because of a short urethra. Okay. They have a greater chance of getting any type of infection because, again, of their shorter urinary tract. UTI, glomerulonephritis, also known as Bright's disease, is an inflammation of the loops. Inflammation of the loops of the nephrons. And then polycystic kidney disease, I actually put that up here in case you guys were wondering what polycystic disease looks like. These are 2 kidneys. You know, all these little bumps on the kidneys. It looks like the back of a toad. Okay, renal cell carcinoma, again related to the kidneys, hydronephrosis, distension of the renal pelvis. So here's another one. This is bilateral hydronephrosis. Okay, enlarged. Let's say this is both the kidneys as well as the ureters. They are distended. Pyelonephritis is inflammation of the kidneys and renal pelvis. Renal hypertension, renal obstruction. Vesicorectal fistulas. This is most common in women. It's an artificial opening between the bladder and any part of the colon. Because if you remember in the cross-sectional diagram of the female anatomy, the colon and the bladder are closely related, so there may be an opening and a communicating between those two structures. Remember with the defecography? Okay, that is the GI portion of it, because we're also trying to analyze if there's a communication between the rectum and the vagina. This is another way to do it. Okay. All right, I'm going to have you guys look this over. You guys can do this on your own, right?
Mm-hmm.
You guys are grown-ups. Right? You got this? Okay. What pathology is presented in the bladder? First of all, the image is too dark, right? But what's obvious?
Bladder is the only thing we
It's
see.
right here. That's a stone.
What?
That's a stone.
I thought it was a bladder.
Well, this is bone, right? It should have the same consistency. It's solid.
Oh my god.
Bone
I thought it was a
is white.
bladder.
It's a lot lighter than bone.
Bladder is the
Well, I thought it was obvious. Yeah, that's a stone.
The whole bladder as well.
So the stone developed in the bladder. What about this?
Looks like the system's backed up.
Well,
There's extra.
1, 2, 3, 4.
Duplication.
It's a
4
myth.
kidneys.
Is that a good thing?
Is that a good? Well, yeah, right?
You can donate and make money.
You donate and make money?
Yeah, that's what I was saying.
Oh no, when if,
So what
then
if
it's
I
not a
need it
donation. You can sell them. Take it back.
That's right.
Yeah, but what happens if you lose that one?
How?
Yeah, that's me being selfish. I'm gonna hold on to mine. Okay. Which gender, male or female, develops cystitis more frequently and why?
Females.
Females, okay. Identify the small triangular shaped object in the distal left ureter. So there's something there, but look at this. Look how thick and distended. Oh, where am I going here? Oh, I can't even see the rest of it, but look, it's distended here. I think the ureter is going somewhere up here. But look how distended the pelvis is. Okay, yeah, so this is a stone, okay, preventing flow, causing, what's this condition called? Hydronephrosis. We saw that one earlier, right? Calculus, right here, stone. What is the specific term to describe the renal pelvic calculus? That's almost as hard as math. Calculus. Seen on the patient's left. What is that called? It's called a staghorn calculus. That's the stone. The stone taking the shape of the entire renal pelvis in its collecting system. Staghorn calculus. See this also? This is also retrograde. Can you see this catheter right here? Okay, so they put that in the bladder and the urethra and they shot contrast. It's retrograde. It's just shot retrograde. It's a catheter right there. Demonstrates prostate cancer with metastasis to the spine and pelvis, so there are some bone changes. Done erect. And we're not seeing the bottom of the bladder over here, so there's some enlargement of the prostate causing the floor of the bladder to be elevated and also indented. What are some conditions that can lead to hydronephrosis? Stones, nephroptosis, tumors, structural and congenital anomalies. Okay, make sure you guys highlight that. Okay. All right, let's go ahead and talk about the procedure. So patient preparation for an IVU, very similar to what? Where are the kidneys? Where are your kidneys? They're right here, and they're in the back, around your abdominal area. So we want to make sure that the bowels are free and clear. So we're going to give them the same prep, like your BE. Okay, like your BE. So light evening meal before, prior to the procedure, you're going to be taking some bowel cleansing cathartic. NPO after midnight, minimum morning of the examination, and you're going to void prior to the procedure. We want to make sure that there is no urine in the bladder. Okay, so it's the same prep as a BE. Patient history, clinical complaints. So we're going to find out about what are you here? Why are you having this done? What kind of allergies do you have? Are you allergic to foods? Any types of medication? Do you have a history of asthma, hay fever, or hives? Okay, because allergies, history of asthma, hay fever, and hives can increase an allergic reaction 3 to 10 times as much. Okay, we said it's unpredictable, but if you have any of these conditions, you may increase your chances of having an allergic reaction. Have you had this procedure done before? And if so, did anything happen? So those are the things you're going to ask them. Did I tell you guys back in the day when we were students, we didn't wear scrubs. We wore a lab coat, a tie, and slacks. That's how we did it. And that's why I was always in surgery, because I hated wearing that, and I dressed up for surgery, and that's where we would find me for the 8 hours I was there. It's a little bit different now, because back then we were able to do surgical procedures without supervision. Yeah. Now you guys have to be supervised. You can't do a portable X-ray. You can't do fluoroscopic CM without somebody there to watch you. You guys know I was hired before I graduated from the program.
Wow.
Did you know that? Oh wait.
Did you own that hospital?
Did you know that I was getting paid before I graduated the program?
Oh.
Why did they take the...
That was in Dr. F's.
They used to be like stipends right before that or something like that?
Well, there used to be stipends. If you guys are familiar with stipends, is that the hospital would give you some money as part of your internship. So they gave you a little bit. The money was used for like uniforms, for food, transportation, whatever. But we had to eliminate it because of competition. Because other hospitals to kind of draw students into, to have hospitals collaborate with a hospital, hospitals collaborate with a school, it was cheaper for them if they didn't have to put out the money. So you had more and more schools who said, yeah, you don't have to give them a stipend, and so more students were going to those schools, and so those hospitals were bringing those students in. So to remain competitive, we had to eliminate our stipends if we wanted to keep our students there. Otherwise, they go to another school and say, well, we have you because you're cheaper. So that's what happened. So the stipends, I mean, it may not be much, but when we were students, we were getting $300 a month.
Today it's like 1,000.
You know what, I guess you're right, because I guess, yeah, I mean, 25 years ago, I guess, yeah, 300 would be much, yeah. Yeah. All right, so again, make sure you check the labs before you perform the procedure. Check for BUN and creatinine, those are your normal ranges. Anything that's elevated, okay, elevated or exceeding, the doctor needs to know, because it's an indication that the patient is in renal or near renal failure, and so we don't want to give them contrast. Okay, so check for creatinine and BUN levels. Make sure that you're asking them if they're on metformin or glucophage. These are some other names for it. Okay? And again, it must be withheld 48 hours before the procedure. And sometimes they'll even say 48 hours after. So whatever the hospital protocol is, I've been in a hospital we say just 48 prior, but I've been to others where they tell their patients they can't take it 48 hours after the procedure as well, so before and after. Okay, any questions about this? Your responsibility, again, make sure you get good clinical history. You're going to select the correct contrast. This is a question, how often should you read the labels?
3 times.
3 times. What are we looking for on the labels?
Expiration date.
Okay. So first of all, yes. Okay. Expiration date, name. Okay. The concentration. We said expiration date. Also, what you want, you're also going to do a visual check. You're going to hold it up to the light. Make sure there isn't anything floating around. Okay. You're checking for the integrity of the bottle, making sure that it hasn't been tampered with. It hasn't been previously used. Remember, contrast is for one-time use only. One-time use, one patient. So make sure it's not one that's already been used or open. And then lastly, what you want to do is also check for the lot number. The lot number. All this information you are going to be writing down on the requisition. Okay, have you guys followed your, have you guys participated in procedures already? The requisition that you get, the order, and you write your patient's history on there, and you give that to the doctor. So on that requisition, you're going to be writing all that. Name of contrast, how much you gave them, where it was injected, the lot number, the expiration date. All those things have to be included on that requisition because it's part of the permanent record. What's the lot number? What does that mean?
Where it was produced.
Where it was produced, where it was manufactured. Okay, that's important. Okay, and then once you draw it up, it says empty container available. What that means is, after you've drawn the contrast, you don't want to throw that bottle away. You keep that bottle until the procedure is done. In case something happens, we have the bottle there, we have the contrast to refer to in case something happened. Okay? So you hold on to the vials, the bags, whatever the contrast came in, you hold on to it until you are done with the procedure. Do not throw it away. Okay? Did I say this was on the test? Probably? Okay. Read the label 3 times. Patient history, selection. Okay, so again, continue with your responsibilities, your patient history, selection and preparation of contrast media, preparation for possible reaction. So again, we're going to perform the procedure where there's a crash cart, or if not, bring the crash cart into your room, making sure that it's fully stocked, especially epinephrine, because that's the first go-to medication when somebody goes into shock is epinephrine. And all you guys have your CPR cards, so you guys are ready to go. And as technologists, if there is a code, your responsibility would be to assist. You're not going to be involved in administering any type of medication, but you need to know where to find that medication in case the doctor or nurse needs it. Okay, so you're going to be there to assist. You may be the one doing heart compressions, or maybe the one that's shocking the patient. That would be your responsibility. But as far as administering medication, that's out of your scope of practice. Okay? All right. Room and equipment. What do we need here? What do we have what do we need? Contrast. Okay, who said that? We need contrast, a syringe, some needles, right? Some tourniquet, a Band-Aid. What else? Emesis basin. Alcohol wipes, cotton balls.
Just alcohol.
Just alcohol. Lead markers, if it's time. I guess some of you guys annotate some of that information in now, but we used to use lead markers that had the time stamped on them. And then, let's see. Crash cart, we said crash cart. Sterile needles, alcohol wipes, tourniquet, emesis basins, lead markers, compression device, we'll talk about that later on, and also some towels. The urinary compression, this is right here, is a method or a tool used to enhance the filling of the pelvic-calyceal system, referring to the pelvis and the calyx. So where are we going to find that? Where are we going to find that on the kidney? It's going to be up here somewhere. right? So what we're doing here is we're preventing the elimination of contrast and keeping it up at the kidneys. We don't want it to flow down to the bladder. The compression is preventing the flow down to the bladder and keeping the contrast in the kidneys for a longer period of time. And that's what the compression paddles are used for. Okay, so we keep it up at the renal parenchyma, so to speak, all right? So the way you would apply it is that the top is at the iliac crest, over the pelvic brim. The bottom is around the level of the as is, and you inflate the paddles over the area until it is compressed. Now there are contraindications for the compression paddle, and they are as listed: possible stones, abdominal mass, aortic aneurysms, okay? Recent abdominal surgery, severe abdominal pain, and also abdominal trauma. You don't want to be using that compression paddle for those reasons. Okay, review that. I'm not going to spend too much time on it, but you guys review that. Putting the patient in Trendelenburg after they receive contrast has the same effect as a compression paddle because by gravity it keeps the contrast up into the renal parenchyma. All right, let's go ahead and start talking about the basic routines. I put a whole bunch of stuff up here, so pay close attention. Before you proceed with the exam, this I put up here, okay, again, you want to get history. You want to explain the procedure, including the transient response. Clinical history includes trying to find out what they're allergic to if they've had this procedure done before. If they had allergies, what is it that they're allergic to? If they have anything to eat or drink is another one, right? Because they're supposed to be empty for the procedure, right? What else are we going to ask them? Are they diabetic? Did you take your
medicine?
Metformin? Because they're not supposed to take it for 48 hours. Okay? So all those things we need to ask. All those things we need to inform them of. Okay? We're going to talk about the transient effects as well. Consent form. Consent form, that's the most important part. We cannot perform the procedure until they gave us a consent for us to do it. If you're sticking them and you don't have the documentation, you've committed battery. Okay? So you got to make sure the consent form is signed by the patient, by yourself, by the doctor. Okay? And then before you do that, you're going to set up your room. Because of its time sequence, you want to make sure that you've selected your technical parameters, your KV is set, your MA is set, everything is set because it's quick. Okay, you make sure you have all your positioning sponges, things of that nature. Okay. So we get our patient into the room. We're going to get them undressed. How undressed are we going to get them? A little bit, a lot. What are we looking at?
Waist down.
Okay, waist down. What else? Possible bra. So get rid of the bra if they're female. Okay, so get rid of the bra. Can you keep their underwear on?